Thanks everyone to coming for Spine. Thanks everyone for coming to Spine Conference. Today's thanks Dr. Pierre for closing the door. Today's going to be an unusual, slightly unusual day that we're going to go over the Academy meeting posters that I felt were of some interest to me, whatever that means. So, does everybody know what the Academy of Orthopedic Surgeons is? Okay, so the biggest orthopedic society is the Academy of Orthopedic Surgeons, AAOS. And it's everybody in orthopedics, which is spine like me, hand, tumor, trauma, sports, joint replacements, a lot of joint replacements, pediatrics. It's a huge meeting. And the meeting is comprised usually in a big area, and this year was in New Orleans, which is a great convention center. And they had 650 posters. So we're going to go over mostly the posters that I found interesting. So posters are basically that. It's a poster that's 5 foot, I think 5 foot by 8 foot, and they have them all in this big hall. So 650 of them, and you can walk through them and learn. It's great. Everybody loves the posters, and you just go through the posters when you have like a spare hour or two between the meeting. You go through the posters. And also the meeting has a lot of like lectures. Like I did a lot of lectures, which are 2 to 3 hours long, and they have many speakers, and they go over a topic. And then there's also paper presentations where they go over new research, where the people have about 5 or 6 minutes to go over their research. So you listen to like 20 of them, and that's kind of tiring because it's a lot of information very quickly. There's many other things in the Academy, so I'm just going to go over the posters that I found interesting. Okay?
Got all the pictures?
Yeah, that's me. This is me at the same time as the St. Patrick's Parade, and there was a float going by getting some beads. So the first one that I want to go over has nothing to do with spine. It has hip replacements, but it's interesting because it's an aseptic protocol to decrease surgical site infections after total hip arthroplasty, which is a huge topic in society and also in orthopedics because why is it a big topic in society? Can you guys just guess? This ballpark guys.
You happened to say it the other day. It costs the government $100,000 per infection.
Costs the government $100,000, and I mean, and who? What? I mean, and the government is like who? Like us. It's us. We support the government, so it's our society. So it's costing us a lot. So we should understand it and try to limit it to as little as possible. And it goes for spine too. Not as critical for joints. I mean, not as critical for spine as it is for joints, but it is very important for us. So I kind of track it to see what's going on. So, like we said, it's a devastating complication of total hip arthroplasties, and it's a huge burden. It's around $100,000 per infection, and that's almost 5 times what a normal cost is, 3 to 5 times what a normal cost is for a total hip. So I guess the normal cost is pretty expensive too, like 20, maybe 25 grand or something. So who gets infections, comorbidities, sick people, BMI or body? We're going to go over body mass index greater than 30. So obese people, revisions get infected. People who are immunosuppressed. Name some immunosuppressed people that we see.
Chronic steroids.
Yeah, steroids. People on steroids like lupus or cancer. Asthmatics, severe asthmatics. We don't see so many of those really. Rheumatoid arthritis. We see a lot of those. And diabetics in general are somewhat immunosuppressed. We have a protocol for this. So the protocol is we screen everybody. We check their nose for MRSA. I mean, you can check other places for MRSA. You can check the back of the knee. You can check the groin. There's all sorts of areas. I mean, we just pick the nose, and it's a very good place to check. And it's not embarrassing or anything. It's very easy. It's not painful. So we check the nose And if it's positive, we give them mupirocin, which is also, we give Bactroban, which is the brand name, for 5 days and recheck it. If they're positive, we give them vancomycin pre-op for sure. And also pre-op, everybody gets the same treatment, chlorhexidine scrub pre-op, but I think we may change that to a chlorhexidine wipe of the incisional site the night before. Also, I want to start hair shaving these people the night before. See if we can get them to do that themselves, because that's one, like, it's probably cleaner to do it at home, and then when they come here, we don't have it in the OR or whatever. You know, I was thinking of we should start that protocol, but I'm not sure how to do it for everybody, because it's just better for the patients to do it pre-op and then clean themselves. And then chlorhexidine is the best treatment for MRSA. And we use chlorhexidine 4% with 70% isopropyl alcohol. And then we do all these things. Subcutaneous suture with skin glue. We do that already. So this was their protocol. And the conclusions, and they had a high-risk group, basically, of their total hips, because this came from Northwestern, which is like a tertiary referral center, so the most difficult cases, the sickest people, go to these city places, tertiary care centers, and they had a 0.39 infection rate, which is excellent. So any questions about protocol to... Now our protocol is even, I think, is even more stringent than this, because we do chlorhexidine scrub pre-op for 5 minutes. Then on top of that, we do the chlorhexidine paint. And our infection rate is extremely low. Like, I think in our 320 cases last year, I think we had 1 or 2 superficial infections. We didn't take anybody back last year. So our infection rate is very low. So,
do you see any TB patients or tuberculin positive patients? Or?
Tuberculosis?
Yeah. History of, I mean, it's when you have to do this.
The last tuberculosis, I remember my first year in practice, I saw 3, because I was at the University of Maryland. And one man was from Africa. One woman was actually from Washington, D.C., and she was immunosuppressed. She had undiagnosed AIDS that she got from her boyfriend. And she had tuberculosis. And then there was a third, too. But since then, I have not seen any tuberculosis. Have you guys seen any tuberculosis? Yeah, not in the community. And I'm sure if it's diagnosed, it probably goes downtown.
Usually they said if there is someone just recently came from India to be checked for this, because some people, they cannot afford to take the medicines for that. They don't have the money, and
oh yeah,
they're still positive.
Oh yeah, it's huge in the rest of the world. It's huge in the rest of the world, and it's not treated. So we don't have many new immigrants in Harford County, really. They're usually, if they're from India, they've been here for a while. We don't have a big influx of immigrants.
No, this was 6 months ago, in the newspaper, that if they come from India, anybody should be checked.
Oh yeah, definitely. It's a huge world problem. Okay. Next is cortical screw fixation versus pedicle screw fixation for lumbar spine in non-osteoporotic bone and biomechanical analysis. This was a study sort of, I think, funded by, in part at least, by Medtronic. And it's called a cortical screw, which is basically still a pedicle screw, but it's put in a slightly different angle. So it's the same thing as it's in the pedicle of the spine, but they call it a cortical screw. So it's just a new name. So the normal path of the pedicle screw is dead center in the pedicle and then all the way into the vertebral body, and you don't want it really going out too much the front of the vertebral body, or you can hit the inferior vena cava or the iliac vessels or the aorta. So in this case, the screw starts inferiorly Hey, Doug. Good morning. The screw starts inferiorly, then goes into the pedicle, and then stops at the end plate of the vertebral body. And apparently this is stronger. So they have a reason to do this, something to do with the way that their implants are designed for percutaneous placement. So this is the standard way for pedicle screws, basically laterally and then straight in, and then this is very short pedicle screw. I mean, I always end it. I usually end it at least a 75-yard line, if not a little longer, versus these cortical screws. So any questions about that, Aaron? So the cortical screws were stronger. They were stronger in pull-out, and they were also stronger in rotation. So this is something just to consider. So any questions about that, the cortical screw placement for pedicle screws? I think this is great for the most superior portion of our construct to avoid the facet above. You see what I'm saying, Aaron? So you don't want to damage this facet. So I think this may be a good idea. I mean, we do it sometimes anyway. So maybe we should try to aim for that. And apparently this is better in osteoporotic bone too.
Is it a different screw?
No.
Just a different path?
Just a path.
Okay.
So it's interesting. It's a biomechanical article. It's interesting.
They look like they're different size screws, don't they?
What's that?
They look like they're different size screws.
They do, yeah. They do.
Laterally.
Yeah, they look smaller in diameter. So that's it. So the next one is, I like this article a lot. It came from Texas. The efficacy of preoperative skin preparation in eradicating organisms before total knee. So when you do the prep, you assume after the prep there's no bacteria there. I mean, it would be shocking if you do the prep and there's still bacteria, right? So this is an interesting article. So chlorhexidine solution, 2% chlorhexidine, 70% alcohol, isopropyl alcohol is the most common thing to use. But they found in foot surgery that after doing that, 30% of the bacteria may still be on the skin in foot. So, Doug, do you have any? Can you highlight know anything more about this?
Yeah, that's absolutely true. You know, and it's called the intertriginous areas. You know, in between the toes. So what you do is you prep it, and you culture it, and you still have a lot of bacteria in between the toes. So it felt because it's a tight space. You know, you got to jam in there or something like that. And a lot of this stuff that I've been reading says, you know, you should re-prep wounds after a certain amount of time. You know.
What about the toes? Do you? When I used to do foot and ankle surgery, I used to exclude the toes. Do you exclude the toes?
I use Ioban wrap, so I prep everything, and then I do occlusive Ioban wrap, so I never see anything.
If you're not doing toe surgery,
yeah. You know, I don't like to see skin at all. I put Ioban over everything I do.
Yeah.
So a lot of this, and then a lot of this stuff, then they'll go back an hour later, and they'll, you know, when you prep, it's clean, and you go back an hour later, and you swab the skin or something, and it's contaminated. And I went to a few infection things. It was a great academy, but one thing that they talked about, there was a place that does joints, and they came into this place, and they had, you know, I don't know, 2% infection rate, and they've cut it down to like less than 1%, and they had a lot of strategies, most of which are common sense, but what we could never get to do here.
Yeah, well, actually, that was our first article. Was this was from Northwestern. Their infection rate was 0.39. By screening everybody for MRSA, mupirocin if they're positive, vancomycin if they're MRSA positive in the nares, and then the prep we talked about, chlorhexidine prep, and then glue, subcutaneous suture and glue.
Right. They also said that for their MRSA patients, they give Vanc plus Ancef. They said that, you know, Vanc is not a very good antibiotic. It's effective, but it's not very, it doesn't act very quickly, and it's not very effective. So they give Vanc and Ancef.
Oh, really?
And then they have this other strategies. You know, anesthesia is in. Anesthesia never leaves the room. You know, everyone is in the room or you're out of the room. Yeah. You know, they had none of this stuff where the implants are being brought in and brought out, X-ray being brought in and brought out.
Operating room flow.
Right.
Traffic.
They talk about the basin, you know, where the nurses or whoever always puts your instruments, you know, and then you take them out again. They say, we never do that, you know, because it's just if something's dirty, then they put everything in this cesspool in the
Right.
back, and then they're pulling the stuff out
In the
again.
water, right.
And
Yeah, what is the point of that? I never understood the point of that.
you know, if it has blood, the nurses like to clean.
The blood is dirty. It's
Clean the big stuff off, you know, so you're not putting dirty blood back in again. But
Yeah, but I think that's probably not a good. You're right. Aesthetically, it looks dirty if it's bloody, but
Right.
blood does not necessarily mean dirty.
Right, and my friend was saying, "Oh, that's you know, it's the same thing. Like I'll go back there and I'll look, you know, and sort of put my hands in and clean the blood off my hands and pull an instrument out again. It's just like, you know, so."
We should maybe stop that. You know what we should do, Doug? Why we should culture that water during the cases? Wouldn't that be interesting?
Yep.
Okay.
Yep. But what do you use for prep?
I was saying to Aaron, my prep is I do HIPAA for 5 minutes, and then clean that off with a sterile towel, and then do also the chlorhexidine scrub, and then let it dry. I always let it dry. I mean, for a couple. One is because you're supposed to.
Wait 3 minutes. Or
Yeah,
something like
I
that.
always wait the full 3 minutes. I never cheat.
Yep.
And
Do you
but
put Ioban on it?
and I put an IBAN
Yeah.
drape. Yeah. Yeah. Also, I never cheat on the time because I want that thing dry because it's a fire hazard. It's a lot of alcohol.
Right.
Sparrow, on the first one, it was 4% chlorhexidine. This is only.
Yeah, this is only 2%. Yeah.
The other thing they talked about is for these MRSA people, positive nares.
You're right.
I use the mucipurin, but they're talking about this. Apparently, the best stuff now is chlorhexidine. Not chlorhexidine. It's like an iodine nasal swab. 3M has got them out now, and they last something like 36 hours, whereas mucipurin is only like 12 hours or something
really?
like that. And you have to keep applying it.
What's it called?
I knew you were going to ask me that, but
We'll find out.
It's an iodine-based nasal thing. Because I had a guy that I operated on about 2 or 3 weeks ago. I was just doing like an ulnar tunnel, but he had MRSA in the past because he's had all this crazy spine stuff and gastric bypass.
Mm-hmm.
And I cultured him. Of course, he was MRSA positive, and I was like, and I gave him mucipurin, but they're talking about these 3M apparently makes them, and they're sort of like these. Iodine-based, and I thought I want to look at them because I thought it might be a little bit toxic on your.
That's what I was gonna ask.
Mucosa, but it's like.
It's okay.
4%. It's.
I know in the lab, iodine killed everything. You remember, like when I used to work in the laboratory, that was the most toxic for bacteria.
Right.
Okay, it makes sense too because in trauma, it's been found that iodine pulse lavage is great for eradicating infections. Okay, so this case, this is 2%. I think we use 4%, so it's a little bit of a different dose there. So the question is, after you do the scrub, that's bacteria in a petri dish. Is there still bacteria? And here's a chlorhexidine scrub, and then we use pre-op ointment, and we do the Hibiclins pre-op and all night before, and also we do a pre-op. So this was a prospective study. It was done in Texas, 99 patients. So they swabbed it before the surgery, and then before they did the prep, and then they swabbed it after the prep. That was basically the study, and they followed by body mass index, which is your weight over your height squared, which is so body mass index. I think it came from longevity studies initially. Like if you had a range within a certain range, your death rate was much lower. And so, I mean, my body mass index is pretty high. I'm like 215 pounds and I'm 5'11", so I'm always right on the cusp, 29, of obesity. I'm overweight but not obese. So it's hard. I mean, for me at 5'11", to be normal weight, I'd have to be 170 pounds. So, I mean, when I was 170 pounds, my wife called my primary care physician and said that I was losing too much weight. She forced me to go to the doctor. She thought I had a problem. Seriously. And my primary care physician says, I think you've lost too much weight. Your wife's getting upset. So
it's always women that make it.
Women are the source of all problems.
Too good compared to her, so she wanted you to beef up. Are we getting recorded on this?
I thought the rule
Yeah, we
was
are.
to always keep your wife happy.
That is a rule. That is a life rule.
Always follow what your wife says.
That is a rule. Always do what your wife says and keep your wife happy. So overweight BMI is 25 to 30, obese 30 to 35, severely obese 35 to 40, and morbidly obese over 40. So the people before surgery that had bacteria, so the pre-swab isolates, their BMI was around 37 or so, and the people that did not, BMI was like 34. So if your BMI was high, if you're overweight, there's a greater chance that you had bacteria on your body, not just normal flora, but something like MRSA. And then after the swab, there's a much higher chance that you still have a bacteria if you have a very high BMI versus lower BMI. So the more you weigh, if you're obese, you have more bacteria before the scrub, and there's a higher likelihood you still have bacteria after they scrub you, which is interesting, right?
You need a bigger scrub.
So the BMI was 38 versus 34, and with isolates post-op or after the scrub, it was 40 versus 34. And 30% of all diabetics harbored bad bacteria pre-op. 30% of diabetics. So patients with diabetes are especially at risk for infection because they already have bacteria on them. So that's interesting too.
Yeah, and the other thing is they, some of these places, they're not doing joint replacements on people with a BMI over 40.
Kaiser, I think, is a policy.
Hospitals at some places are saying, you're not doing this procedure, you know, I don't care what, this person...
Because it's a high risk.
Because it has a high risk, and you know they're worried that their results, you know, if they get 1 or 2 infections down the road,
right,
compared to a place that doesn't do it,
they get penalized by Medicare.
Like dogs and so.
Well, you get penalized. It's not just reputation. You lose money.
But it's a numbers game. So the other thing that I got out of this is that there are people that have that were morbidly obese and have gastric bypass,
yeah,
and then they have surgery,
yeah,
they still have a high infection rate, even though they bring their BMI down.
Well, those patients are special. They're malnutrition.
That's what they're saying.
Yeah.
They're saying even though their weight is low,
yeah,
it's not protein that they've got. They've got all this sort of, they're still a quote, you know, obese person in a thinner person's body.
They're complicated.
Right. And
they get stress fractures.
So the BMI
yeah,
is not a great indicator for obese. And they have, you know, these crazy cases are outliers. This guy from Mayo Clinic, he presented this guy. Guy who comes in.
Remember, I'm recording everything, so it's got to be G-rated.
Yeah, it's G-rated.
Okay.
He said, well, you know, you need to lose some weight, you know, and the guy says,
yeah,
well, I've already lost 700 pounds. And he goes, you mean you lost 100 pounds, you gained it? And he goes,
yeah,
no, I lost 100 pounds, 700 pounds. You know, this guy was in...
he was like 1,000 pounds.
Yeah, he had an enabler, his sister. And, you know, finally he got to be so big, you know, he would get up out of bed, he'd go to the bathroom, and he'd get back to bed. And then one day he got up out of bed, and his foot went through the floor of his trailer house, and he got stuck. And the police came.
Is this a real story you pulled on our leg?
It's a true story.
Okay.
They can't get him out of the door, so they have to cut the roof off this trailer house and, like, crane him out.
And he did a total hip on that guy?
Knees. Bilateral total knees.
Well, what happened? He got infected.
No, he was an outlier, but it's just, you know, they were presenting these crazy cases. You know, they had someone who had a BMI of 90. You know,
90?
She was like 4'11" or something, you know, and she was like, you know, 300 or 400. She had like the largest BMI, and they did a hip on her, and she had complete disaster.
Well, I could have predicted that one.
But you know, well, yeah. So someone comes in and they've got they've got terrible arthritis. They've got, you know.
Yeah. Also, patients don't want to hear it. They get upset. You know.
Yeah, and they always say, well, you know, if I don't do them, someone else is going to do them.
Yeah.
So, but it's.
Let me keep rolling here. So this study also found that the ChloraPrep was 90% effective of getting rid of all bacteria. So that's good, but it certainly isn't 100. So that's kind of interesting too. And BMI was a big factor. Diabetes was a big factor. Okay, so any comments about that? Okay, this I thought was interesting. It's the association of preoperative pain catastrophization and postoperative pain intensity in primary total hip arthroplasty. So again, this is not a spine article, but I thought it was very interesting. So there's a certain thing called pain catastrophization. So I thought this was a good example. Is this guy here, man, I got a C on my exam. And he starts thinking, well, I could lose my scholarship. And then he said, oh, then that would mean I have to take out more loans. The world's over. So it's basically worst case scenario. And the analogy I give to patients is when you step on the plane, don't think about all the airplane crashes that you've seen in movies and everything. That's the worst thing you could do. You're going to drive yourself crazy. And it's not necessary. It's really, really unlikely. It's the same thing for surgical complications. Is, you know, it's a very low probability we're going to have a problem like, you know, a catastrophe. Possible, but very, very unlikely. So that's catastrophization. And this is one of the questionnaires, so you understand what it is. It's like, it's terrible. I think it's never going to get better. It's awful. I feel that it overwhelms me. I anxiously want the pain to go away. I keep thinking about how much it hurts. I keep thinking about how badly I want the pain to stop. And magnification, I become afraid that the pain will get worse. It's a fear of pain, actually. I keep thinking of other painful events. I wonder whether something serious may happen. In spine, the most common was, I'm going to be paralyzed. I'm never going to be able to walk again. I'll never be able to take care of myself. That's the biggest spine catastrophization that we see, don't you think? And then, so this is catastrophization. And what this study found was that preoperative pain catastrophization predicts the pain intensity. So the patients that have a lot of feelings of catastrophization have a lot of pain post-op and don't do well after total hip arthroplasty. And it's a independent variable to depression and anxiety, which are also other psychological factors that give you poor postoperative pain outcome. So pain catastrophization is a serious problem. So any questions?
Do you think the converse is true? People who don't catastrophize tend to do much better?
Yes,
And
I do.
We see that. People who walk in and say, I want this fixed, this is the right thing to do, and then they do great.
Yeah, I think so.
Where was that study from? Where's that guy from?
UK.
Okay.
Nuffield, Department of Orthopedics.
Yeah, Newfield, yeah. That's where Charlie was.
Was he?
Big joint place. Yeah.
Okay. So I thought that was kind of interesting. And then if we're suspicious, I think we need to get more psychology consults and we need to get more psychiatry consults to help these people, and our results will be better.
Sometimes they're not surgical candidates at all, I think.
Yeah.
They just, no matter what you do, it hurts. And
Right. So, I mean, I often say, I will do your operation, but you have to see someone first to make sure you're stable. And whenever I do that, I'm always happy I did it. And the patients do better. Okay. So, okay, the next one is from Hopkins. Clinical results after direct intralaminar screw pair spondylolysis. So this is not something that I do, so I found it interesting. They fix pars fractures. So just as a review, a pars fracture is a fracture between the two facets. Pars is the place between the two facets. So here's one facet, here's the other facet, and a break between them is a pars fracture. They can lead to, that's it, spondylolysis, and it can lead to spondylolisthesis, the bone sliding. So their hypothesis was that if you had a very large defect, you would have poor outcome if the bones are separated more. And they collected data prospectively. They had 32 patients they did this to, and most of the people came back 97% follow-up, and most of them were competitive athletes, so they were probably high school kids with pars fractures that hurt. And we see them all the time, right, Aaron? And they had non-operative treatment for 22 months, and they had good follow-up. And here's a fracture of the pars, and they measured how wide the pars were. So what they did is they opened the skin at the area of the pars. They debrided the pars defect, and they put bone graft in it. And then percutaneously, they inserted these 4.5 millimeter screws into the pars at the very bottom of the lamina, and then across the fracture, and then into the top of the facet area, basically fixing the fracture. And they found 90% had improvement. You can see here the visual analog scale. This is pre-op and that's post-op. So as the defect got bigger, 1 millimeter, 2 millimeter, 3 millimeters, 4 millimeters, 5 millimeters, they didn't do so well, but they still did pretty well though. And one patient had to go on to a fusion, and two of the screws broke, which means it didn't heal. And one got infected that required to take back to the OR, which is sort of a high-ish infection rate if it's 32, yeah, 3%. So any questions about that, fixing pars fractures? I mean, my general thoughts are, you know, this is not so much like a fracture, like a broken ankle, but it's a defect that is genetically predetermined and also activity determined. So it may just keep recurring, even if you heal it. It's healed clinically, totally clinically healed. It may fracture again just because it's an inherent weakness. It's not. Don't you agree, Doug?
Probably never heals. Probably
yeah.
The hardware holds it in place.
Yeah, it's like a disease.
Non-union or.
It's a disease process. It's an inherent weakness of the spine.
Instead of fusing, it's two things that never fuse. So
never totally remodels to be normal. Yeah. Yeah, that would be interesting if you could somehow magically cut out the fracture and see what happens to these people. It probably is not a normal pars, you know.
Well, but it said most of them were athletes, so you don't think it's like a repetitive.
Yeah, if they're an
injury.
offensive lineman, they're going to keep stressing it. If they're a lacrosse player, they're going to keep stressing it and keep injuring it.
But that's not genetic, so you could
stop playing sports.
Right.
Nobody stops playing sports, not in Hartford County. Okay, so
almost no place. I went to a sports talk, and they're talking about these women with repetitive ACL injuries. These women's soccer players, and 4 times on one knee and 3 times on the other knee. They
don't stop.
It's
you can't. You might as well ask someone to walk off a cliff and stop playing lacrosse. It's not going to happen. Let's be realistic. Okay. So then I thought this was interesting too. Preoperative narcotic use and its relation to depression and anxiety in patients undergoing spine surgery. So this was done in Vanderbilt, where they had 583 surgical cases for a structural lesion, which I found kind of interesting. Is like, do they do surgeries for non-structural lesions? And they did a pre-op Zung depression scale, and then they also did a modified somatic perception questionnaire. I'll show you that. And they controlled for sex, age, smoking, employment, prior surgery. And they assessed depression and anxiety. And they found that patients with depression and patients with anxiety took a lot more morphine pre-op than patients that are not depressed and no anxiety. So this is the morphine equivalence of 35 milligrams. So the point of this is these patients need counseling, and it will help them with pain control if they're counseled, and it also will help them become opiate free. So it's another thing we always think about, depression and anxiety. So a much higher probability of them much higher dose in opium. Any questions about that one? Okay. So this is just a questionnaire they did. This is the Zong depression score. I feel downhearted and blue. Morning is when I feel best. I have crying spells or feel like it. I have that during office hours, usually at noon. I have trouble. Just kidding. I have trouble sleeping at night. Anybody with kids will say yes to that. Okay. So the next one is was by Dan Ruitt in St. Louis. Postoperative hematoma after anterior cervical spine surgery, risk factors and outcomes. So this is always a big fear of ours, that someone develops a blood clot in their neck and it pushes on their trachea, the windpipe, and then they stop breathing and they die post-op. It happens. I've had one case where the patient developed a post-op hematoma. She happened to be a nurse. She called me on my cell phone. She had my cell phone from the office cell phone, and she says, I'm pretty sure I have a hematoma in my neck. I'm having difficulty breathing. So I called the ICU attending. I said, please go intubate this patient on the floor. She may die if you don't do this. So he did. He ran up, intubated her, took her to the OR and washed it out. But it happens. So this is a study of a very large practice of how often does it happen, and they kind of studied it. You know, my patient did great, but that's why I admit everybody and I observe everybody. So they prospectively recorded all patients from 95 to 2012, one surgeon, Dan Rue, one academic center. They measured body mass index, blood loss, things from the surgery. So it was 2,300 spine surgeries, a lot, and they had 17 retropharyngeal hematomas, which was an incident of 0.7%, so maybe 1%. Not terribly small, you know. This is just the development of the hematoma. 65% of them were within the first 24 hours. So if it's going to happen, it usually does happen, you know, 24 hours post-op. But also 35% of them, a third, developed it day 3 and day 9. So it can happen still. So it's something that we have to be, you know, wary of, that if patients call, they can still get this problem in the first week post-op. So we have to be careful with these people. Almost everybody had a drain, but it didn't help every time. A third of the people still had the drain when the bleed happened. And the one case that I have in like 15 years, she had a drain too. And if you have a rapid bleed, the blood doesn't go out the drain. The drain is more for just serosanguinous fluid, not for blood if you have a bleed. And the vascular surgeons will tell you that drains are not for blood. Drains are for like just exudate, basically. So they removed the hematomas in everybody. 12% of them required a cricothyroidotomy, which we're going to go over. And bleeding was found in a third of them. And they were all intubated post-op. So you may say, what's a cricothyroidotomy? So if you feel, everybody can feel their Adam's apple, right? That's the most common one in their neck. That's the thyroid cartilage right here. This is the larynx. So what does the larynx do? What's a ballpark? It helps us with swallowing, and it also helps us with our voice. It's a very critical structure. If you have a problem with your larynx, you die. So if you have pressure on your larynx, you know, you will die. So if you have a hematoma there, you can't intubate through the mouth because there's a block there. So you find the thyroid cartilage and you go down. The next cartilage that you're going to feel is the cricoid. So you go just below that and cut it open. So you make a incision, either longitudinal or transverse. I think longitudinal will bleed less in the midline. And then you go in, feel the cartilage with your finger. You go in and you take a knife and what I've been taught is cut an X and then put the tube down there. And you'll save a patient's life by doing this. Have you ever done it, Doug?
Yeah. It was dramatic. I was an intern.
I hope to God I never have to do it.
It was, and this guy he was a, you know, sort of a big obese medical patient on the medicine floor, and he was eating breakfast, you know, and he had like and they could 4 anesthesiologists could not intubate the guy.
Yeah.
And you know, it was really dramatic. You know,
yeah.
the cardiology attendant, the guy needs a trach. You know.
Yeah.
You look around and you're like, can you do a trach? Yeah. I was an intern. I was probably, you know, 3 months on to it.
Yeah. Who's more confident than the surgical intern? Right?
And there was a respiratory therapist there with me, and if it weren't for her, I couldn't have done it. And they had a kit, and you know, I made the incision, and she had one of these little metal airways, and I'm like, you got it? And I made the incision. She put it in, and guy coughs up, and he breathes, and it was like, wow. And they said, have you ever done one before? And I go, yeah, of course. I did one like 2 months ago on a dog in the lab.
Yeah.
And it was like a life-saving maneuver. It was incredible.
Yeah. Hey, you did save that man's life. When it does, you have to be bold. When you, I mean, that's the theory. You can't be afraid of bleeding either.
There were probably 20 doctors in this room. There were 4 2 anesthesia attendings.
Yeah.
No one, like, they were paralyzed. No one could offer this.
Well, you can't ask a medical doctor to do a surgery. They're not comfortable with it.
But it was a life. I mean, it was like, wow.
Yeah. We should probably train ourselves every so often to do it.
And I think some of the guys are doing them in the OR every now and then, like, you know, a general surgeon or two, I think, of done one, you know, because ENT or something is never around.
Yeah.
It's on a weekend or something, and they got this, you know, like in a trauma or something like that.
Yeah, they do them.
The general surgeons will do it. It's clearly life-saving.
Yeah. Okay, so with the risk factors were people with DISH or OPLL, diffuse idiopathic skeletal hypertrophosis, OPLL, longer surgeries, more levels, so big surgeries, and heparin post-op. Things that were not risk factors were ACDF, corpectomies, implants, neurostatus, smoking. So any questions about hematomas? So I thought that was a very nice article, very helpful. So the next one's dysphagia after anterior cervical discectomy infusion, incidence and risk factors. This is from joint disease. So dysphagia is a common complication after ACDF, maybe from swelling, maybe from traction of the esophagus with our retractors, maybe from an injury to the recurrent laryngeal nerve, maybe direct ischemia of the esophagus if you're pulling on it real hard during a surgery because you have to retract the esophagus to access the anterior disc. So, you know, what's the incidence of it? And this was a study which goes over the National Inpatient Sample Database, the coding, and see how often it happens. So, what's the recurrent laryngeal nerve? The recurrent laryngeal nerve comes from the vagus nerve, the 10th cranial nerve, which travels in the carotid sheath, and then it exits. The recurrent laryngeal nerve is a branch of that, and it exits different areas on the left and right. On the left, it goes under the arch of the aorta, and then travels upwards between the esophagus and trachea. And on the right, it goes over subclavian. Now, the biggest, and you may say, what's going through your mind, Aaron, is why do we always do it left-sided? I'll tell you in a second. So, I just wanted to go over swallowing. Swallowing is really important to understand. The food goes in your mouth, okay, and then goes into the pharynx. And there's the oropharynx, and then there's the nasopharynx, and they meet back here in the back of your mouth. And then as the food goes down, it goes past the base of your tongue or your soft palate, and then the epiglottis is all this is your larynx from here to here. And that's where when we do ACDFs, we're right on the larynx, right? We're like retracting it. The epiglottis goes down and blocks the trachea, so the air doesn't go down the windpipe, and then the food goes behind it. And also the soft palate closes down over the esophagus, and that allows the food to go down. And then it opens back up right after we swallow because we have to breathe. Okay? So 1 out of 100 people around, the right inferior laryngeal nerve is non-recurrent, and it branches right off the vagus nerve, right at the cricoid cartilage, right where we're doing our surgery. So 1 out of 100 people, it doesn't recur. It just comes right off and goes to the larynx. So you could cut it. So that's the whole purpose of going left-sided. But it's sort of been studied. It doesn't make a difference. What are you thinking, Doug? So so the results in this case, when they studied, there was a 1.8% dysphagia rate. People who had dysphagia were in the hospital a lot longer, 5 days versus 2 days. People with dysphagia, the hospital charges were $60,000 versus $37,000. And people with dysphagia were more likely to die than people with not dysphagia. And serious dysphagia is a big problem. Some people need a peg, you know. The dysphagia after ACDFs is correlated with the number of level fused, increased hospital volume, teaching hospitals. People who had dysphagia were more likely to die, and they're more likely to aspirate. It's probably how they died. It's a low rate. It was 1.8%. Okay. So any questions about dysphagia? So the next one's discectomy in patients who have depression. So the reason they did this is if someone's depressed and they have sciatica, should you not do the discectomy? Like, they're not going to get any better because they're depressed. Like, so we get this all the time, actually. So they studied this, and they found that after doing a discectomy, the depression markedly improved. So this is the depression got worse. This is the depression stayed the same, and this is the impression. The depression got much, much better, 82%. See that? So patients, their depression significantly improved after doing the discectomy. So the point is, you don't do discectomy for depression, but rather if someone's depressed and they need a discectomy, don't let that stop you. Do the surgery. In fact, it's going to help them with their depression. So I thought that was very interesting. It was like counterintuitive to what I thought. So
did it matter if it was acute or chronic?
I don't know. So it improves depressive symptoms. It helps their global health, quality of life. Okay, this is a good one. This measured. This is from Michigan. It measured subcutaneous fat thickness in lumbar spine surgery and infections. So in other words, they, instead of just measuring BMI, which we talked about, it measures how much fat's right where you're doing the surgery. So obesity is definitely a risk factor for SSI or surgical site infections. And BMI, it doesn't account into where the fat is. So if you have fat right where you're doing the surgery, they think you're higher at risk for infection, which is interesting. And it's a problem in hips too. Some patients have very, very, very deep hips, and I think those patients are more likely to get infected. Now this is not hips, this is spine. So they had 149 patients, and they measured everything, and standard stuff. They measured from L4. So basically, you measure from the tip of the posterior process of L4 to the skin. So that's basically how deep your wound is. And they found that if your wound, if that measurement was 51 millimeters or higher, their infection rate was 24%. And it was a much, much better indicator than BMI. So this is a guy we just did, Aaron, because I just want to see how big was he? 56 millimeters. I mean, he's at 25% infection if he was in this study. And they're hard cases. So the thickness of subcutaneous fat is a risk factor for SSI and lumbar procedures, while the BMI was not that much of a risk factor. So if you have over 50 millimeters of fat where you're doing your surgery, you have a 10 times increase of infection. That's an amazing statistic. This is me in the 3rd grade. I used to lift weights. So the other so any questions about that? So this is something we can counsel patients pre-op. Is like, look, we're measuring it here. You're at high risk for infection because of this. And so next is cervical radiculopathy incidence and what kind of cases. And I just saw this a little bit interesting. Is like, where are most of the cervical? Where is most of the cervical areas that need surgery? And we already knew this. It's at C6 and C7. So C5, C6, C6, C7 are the vast majority of where these patients need surgery. It's just an incidence study. Okay, the next one's stiffness after a pan lumbar fusion. So if your entire lumbar spine is fused, can you do everything that you want to do? Activities of daily living, are they affected? And that's what this study. So this is what we're talking about. This is one of my patients actually. The whole lumbar spine is fused. I didn't do this all at once. This happened over like 15 years. The whole lumbar spine is fused, and they follow these people. How do they do? It was prospective, etc. And they found that their activities of daily living were not increased due to the fact that their entire spine was fused. So people whose entire spine was fused from T2 to the sacrum did worse than people fused from T12 to the sacrum. Because I think some people develop motion in their thoracic spine if their entire lumbar spine is fused. In fact, I'm sure of it. So they have to move from somewhere. So any questions about that? So I thought this was interesting. Have you heard about this opportunistic screening of osteoporosis through CT? So this was done, and this was originally in 2013 from the Annals of Internal Medicine. What they did is they found that they can very reliably measure osteoporosis through CAT scans. So you get a lot of people that go through the ER, they get a CAT scan. A lot of people. And you can measure their osteoporosis from there. So what they did is through a normal CAT scanner and through a normal PACS, they circled an area, a standard area at L1, as long as L1 didn't have a fracture or tumor, etc. and they found that that was just as good as using a DEXA scan. And the reason why this is, and this was also this was the article from Annals of Internal Medicine, but also this was a poster at the Academy that did the same thing for people who had fractures of the spine. And the basic premise is people don't get the DEXA scans. They don't follow up with osteoporosis. So in the ER now, with the same technology that we have, it's very, very easy for them to measure bone mineral density. So when they leave the ER, you can tell them, look, you have osteoporosis proven by this CAT scan, and follow up with your primary care physician. So this is something that I think we need to start doing. This is a great idea. So that's basically it. It's called CT attenuation, and all you need is a PACS and a CAT scan. So any questions about that? I thought that was interesting. I think we should start doing that, Doug.
CT attenuation.
Yeah, CT attenuation.
So it sounds like something else, something separate that the radiologist would have to read.
The tech will do it. But if they do protocol, it's like,
right.
It's a freebie.
Right.
And it's a great service to patients to say, look, you have osteoporosis, so you don't have to say they get a DEXA scan. Okay, the next one's, what's the safest way to move a football player after suffering a cervical spine injury? I thought this was fascinating. So there's different ways to move a football player. You can log roll them, you can lift them and then slide them through your legs, which I've never seen before, but apparently it's a safe way. Or you can do the 6-man technique, which is one person holds the head and then one person on each shoulder, one person each hip, and one person for each leg. And what they did is they took 6 cadavers, or 5 cadavers, fresh cadavers, and they cut everything at C5, C6, everything. So it's a totally unstable spine. And then they put transducers to measure the motion of these cadavers while they moved the football players in a cadaver in pads. And they found that by far the best, the most stable way is the 6-man technique. So the least amount of motion in the cervical spine when you have a complete cervical spine injury is a 6-man technique. One person at the head, 10 pounds traction, and then 6 people, shoulder, hips, and legs. I thought this was a great study.
What do? They lift the person while someone slides a board up?
Yeah, and put them in the ambulance. So that's when patients can get an injury. When you move them, and then once they're stabilized on the stretcher, then they're safe. So I thought that was great.
Interesting.
And that would definitely change what we do. Okay, the next one is postoperative opioids. We gotta wrap up. We're getting late. Post-op opioid administration in a bone healing model. So when you give people a lot of narcotics, does it stop bone healing? And what they did is they took these little cute rats and they plated the femurs. One group they gave a lot of opiates, the other one they didn't. And they found that at 4 weeks and at 8 weeks, the fracture was much weaker in the opioid group. So opiates delay fracture healing. It's kind of interesting. So at 8 weeks, here's control, no morphine, and this is rats with morphine. The fractures are a lot weaker with morphine, which is interesting. I won't get into that. So basically, try to decrease opiate use post-op. And it must be the same thing for spine fusions, I would gather. Okay, the next one is opioid use, pain intensity, and satisfaction. So satisfaction is how we're going to be paid now by Medicare. So we've got to make sure everyone's satisfied. And people are satisfied if they get a lot of opium? And the point of this study is they don't. They're worse, actually. So the more opium they get, the worse they did. So if you give someone opium, more opium, does it make their pain go away? And so they followed this, and they found that people required more opiates because they were on it before, because they smoked, depression, anxiety, and the patients that take more opioids report greater pain intensity and less satisfaction with pain relief. So just because you give people more opium doesn't mean their pain's going to get better, which is a little bit counterintuitive.
That's a little biased though, because this group is out of Boston and they do some really good stuff, but probably the people that they give a lot of opium to, they those people probably want 6 times more than the doctors are willing to give them.
Yeah.
The normal person gets 5. These guys want 50, and they're mad because they're not getting 500. So
Yeah.
it's,
I don't know what the answer is to that.
they've done some really good work. They looked at non-anatomic hand pain,
Mm-hmm.
and I get that a lot too. Non-anatomic
Yeah.
foot pain, where people just hurt.
Yeah.
And they say, you can figure these people out. They come in and you do a questionnaire, and if they've got non-anatomic hand pain,
Yeah.
they're like they shouldn't be seeing a surgeon.
It's
Because
not surgical.
There's
right.
nothing that no matter what they do, these people are always.
It's not a surgical problem.
Right.
That's all.
Right.
Yeah. So this, I just want to go over this, is Aaron, this is like I want to tell you about this. There's a collection of bones in Cleveland called the Heyman Todd Collection. You heard about this, Doug?
Yeah, there's a guy, Peter Scholes, who's an orthopedic surgeon who did some work on this with club feet, I think.
A lot of studies have been done. There's this huge collection of skeletons, 300 skeletons. I think it's the biggest in the world, and they have them for research. And it was an anatomist and I think somebody else, and they put it together. And you can go there and do these incredible anatomy studies.
Have you been there?
No, I want to go though. I've heard about it many, many times. Okay, this is the last one, is lumbar fusions. I thought this was interesting because this study was done by Cigna. So this is a poster by an insurance carrier. And what they did is they followed spine fusions for lumbar degenerative disc disease. And how do they do? And I mean, you don't have to guess the results. They did very poorly. So 30% after the spine fusion for lumbar degenerative disc disease, and it's not for spondylolisthesis, it's not for fracture, it's not for tumor, it's for just lumbar degenerative disc disease. And what they did is interesting. They followed the codes of 22612, which is posterior spinal fusion, 22630, which is interbody fusion to a posterior approach, and also 22558, which is anterior lumbar interbody fusion. And then they followed what they did in that the patients who had those fusions after 2 years, 70% still needed more services, around 10,000 a person. 95% with pre-op opiate use required 3 different narcotics at 2 years. So the patients who come in for lumbar degenerative disc disease on opium, they never get off of it. And 97% of customers of them needed an average of 39 prescriptions per year, $2,500 a person. A third of the patients that had spine fusion for lumbar degenerative disc disease still had post-op pain procedures afterwards. 14% needed more surgery. So 14% needed more surgery. 7% of the patients had complications. 1% infection, which is probably reasonable. A third of them still need pain intervention. A half of these people had more CAT scans, more MRI scans. And 32% after 3 years still needed physical therapy, chiropractic, acupuncture. So if you come in on narcotics, it's like 97% chance you're going to be on chronic opiates. And that's basically it. So
could you just go back to the exclusions? It looked like they excluded fractures.
Yeah.
And infection.
Fracture, tumor, infection, spondylolisthesis, and deformities, scoliosis. So this is for pure lumbar degenerative disc disease. This is something we know. I mean, that's how we practice, right?
Right.
I tell them it's not a good treatment for you.
It's almost the correlation he just talked about with the hand.
Well, you could. I'm not sure if that's true, but we could talk. We don't have time to talk about that. So any questions?
That was great.
Thanks for coming, everybody. See you next month. Happy Easter for those who celebrate Easter.